Good afternoon. I am Brit Gould, and I'll be your host today. On behalf of everyone at Echo, welcome. Thank you for joining us. We are thrilled and honored to be joined by this team from Guthrie today. They will share with you their experience at implementing telehealth across Guthrie and how they used Echo in the process. You'll hear directly from David Hall, Associate Vice President of Operations and Virtual Care, Dr. Jagmeet Singh, Chief of Nephrology and Physician Lead for Telemedicine, Alison Bidlack, IT Application Manager, Virtual Care, and Ryan Hewitt, Application Analyst, Virtual Care. Dave will start by sharing a bit of a background on Guthrie and how they got into telehealth. Dr. Singh will then share his physician perspective. Alison and Ryan will share their experience of expanding telehealth across Guthrie, including a few surprises that they ran into and had to solve. Dave will then come back and share some thoughts on telehealth post-pandemic. After the presentation, we'll get to a Q&A session. Any questions you have, go ahead and submit them to us. At the bottom of your Zoom webinar screen or window, you'll see a Q&A button. Click that, enter the questions there so we can get to them, or as many as possible, when we get to the Q&A portion. With that, I'm excited to turn this over to Dave to get this started. Dave?
All right, thank you, Britt. So we'll jump right in. So Guthrie is a nonprofit integrated health system spread across north central Pennsylvania and the southern tier of New York. We currently have 5 hospitals, about 45 regional clinics across 24 communities. This includes a medical school, a research institute, and then an employee base of about 6,000. That includes 900 RNs, 81 residents, fellows, medical students, and over 500 providers. So we talk a little bit about our numbers. What do we do per year? So we currently do about 1.7 million outpatient visits per year, about 113,000 ED visits and 25,000 admissions. Spread across 5 hospitals. And then we have 2 hospitals that are birthing centers. We do about 1,600 births a year as well. We have an array of specialty services such as ambulatory surgical centers, an oncology center, weight loss center, and an award-winning cardiovascular service line. We continue to really invest in our technology. And as a 10-star Epic shop, we place more than we place the care really in the patient's hands. So we currently have about 113,000 active eGuthrie users. And we continue to grow that number month over month. Right now, we are piloting some self-scheduling options. And this year alone, we've done 22,732 self-scheduled appointments. So we jump right into it and really want to set the stage for my colleagues who will be presenting after I'm complete here. I want to talk a little bit about the continuum of care. So from a strategic perspective, the system decided to start piloting telemedicine programs about 3 years ago. With some mild success, we began building infrastructure that we felt would enable scalable solutions, and really wanted to ensure that those scalable solutions met each of the continuum of care models. It's really interesting to see how our industry is shifting, pivoting very quickly due to the COVID pandemic. But the continuum of care will really never change. So as we continue to retool our industry for this shift, we need to make sure we're efficient in the solutions that we develop across the spectrum and ready to operationalize these programs as we deem necessary for our organization. What's interesting to note too is during the infrastructure phases, we really put a lot of emphasis on the patient and provider satisfaction. So during our original hub and spoke model that we created with a number of our communities, which we'll talk about a little bit later, we wanted to make sure that we captured the voice of the patient. We wanted to make sure that this was well received, that the care was optimal, and that it's a program that we felt was scalable and patient consumer buy-in would increase in utilization. So we set up a survey monkey to start with, very simple, straightforward. And one of the questions was, would you recommend this service to others? And we had an overwhelming yes. Lots of comments. Total N on this question was 252 over a year and a half, about 2 years, closer to 2 years worth of surveys. But it's interesting to note that as we've started to shift and put the technology back into the patient's hands in their own homes, that patient satisfaction has dropped quite a bit. Um, so we find that when we control the technology, we really provide a superb experience for our patients. When we allow the patients to, or we try to shift that technology focus to the patient's control, they have a very difficult time, which leads us to believe that the knowledge, the technical knowledge across our patients, serving multiple generations, is vastly different. So how do we continue to expand and build upon those different technology capabilities to ensure we get a same seamless um, uh, experience as we do when we control the technology ourselves? So I'd like to take a minute to just quickly introduce one of my colleagues, Dr. Jagmeet Singh, who is the Chief of Nephrology at our Sayre Hospital, our flagship hospital. He is one of our physician champions, and he's been doing telemedicine for a number of years now. So, Jagmeet.
Thank you, Dave, and thank you, Echo, for giving me this opportunity to share my experiences for the telemedicine and how can we bridge the gap in telemedicine. So as you can see, the topic of my discussion is bridging the gap in telemedicine. So first of all, I want to say that we are a staunch believer in telemedicine. We believe that medicine is going to be delivered in a completely different way. Let's say in 2030, 2040. We are using medicine technology for dating, for banking, for Netflix, for everything beside the medicine. So I think telemedicine is the way to go, and it's going to be completely radically different how the medicine is going to be delivered. So telemedicine is the future. But what happened with this pandemic COVID-19, we have been pushed into the future. And now we all are struggling to see how we can get there, how can we can get the telemedicine right. So as I said, I'm a staunch believer in telemedicine, but I also am a very strong believer in physical examination. I think physical examination is really important. Without physical examination, any physician and the patient encounter is just like video conferencing or FaceTiming. It doesn't have what it is needs. Being a nephrologist, when I see the patient, I need to auscultate the patient. I need to listen to the heart sounds to see, what's going on. Want to listen to his lungs to see whether patient is in volume overload or, patient is in heart failure. So physical examination is very important, not only for cardiologists, I will say, for pulmonologists, even for everyone. Every physician physical examination is very important. And we in Guthrie also believe that, physical examination is important for diagnosing, but it is also important for patient satisfaction. I think it builds a relationship with the patient when you do the physical examination on the patient. So with this background, we started our journey. And, for the physical examination, it's not what I think. I think, again, there's a very nicely, beautifully written article by Dr. Paul Hyman about disappearance of primary care physical examination, losing touch. I think we all should read this article. It tells you how spending more time on the screen, we are losing a very important tool for the physical examination. With this baggage of losing the physical examination, but still loving the telemedicine, we started our journey in Guthrie much before the pandemic happens. Uh, in the initial times, in the initial times, we were started having just video conferencing. It was very good for, my simple follow-up patients, hi, how are you doing, reviewing the labs. But again, we were lacking something, putting the stethoscopes on patient chests, I was lacking that part. So we thought, we need to take a further step. So what we did, we started using LPN and a clinical assistant to kind of help me doing the physical examination. So she was listening on my behalf, which is good. I trained her. But then again, it is to make the diagnosis, I have to rely on patient, or not on, I have to rely on the nursing, somebody else, so which is not the best one. So then I discussed with my administration. I said, we need a stethoscope. Without the stethoscope, it's just like a FaceTiming or iPhoning, video chatting with somebody else. So we bought some stethoscopes, and there we didn't go. I don't remember the name of the stethoscope, but they were not really. First, their quality was not good. They didn't have noise cancellation, and there were so many wires entangled. The regular visit, I just boom, boom, boom. 15 minutes, I can see a patient, but I was requiring more than 20-25 minutes. We have to mute one and then the other one. So it didn't go the way we wanted to go. And then we were kind of struggling, and then we started with an echo stethoscope. This is the kind of a game changer for us. If you look at this one, it's a very simple stethoscope. It looks like any other stethoscope, but it's like Tesla. It is a completely different thing. So first, you can amplify the sounds. You can amplify the sounds from your end. If you're not listening it well, you can increase it. It goes up to 40 times. So you listen to very good heart sounds, very good breath sounds, and then it has the option of noise cancellation, which is really good. I think all the modern stethoscopes have it. The quality of noise cancellation is really good here. And then, which I will show you further down the presentation, that you can look at the sounds, which is kind of very amazing. So you can visualize the sounds. And, we are an academic institute here. We have residents, we have fellows. So it's also very good. You can record this one, you can save it, and you can share it. So that was the one. And this is how we started our journey with the Echo. So this is our, regular clinic setting. Basically, if you look at the left-hand side, I'm a provider or a specialist, is most of the time sitting in his office. And the patient, who is generally 200 miles away, 300 miles away, we have a lot of clinics, smaller clinics. We want to provide patients care closer to their home. So patient goes there, and then the nurses, if you look at the picture, I'm there looking at talking to the patient, and the nurse comes using the stethoscope, which transmits sound to the iPad, and then iPad, I can listen it right away. So, and we did take the permission of the patient before clicking this picture. So this is a very kind of a very present and very nice workflow we have it here. So, and then we are using it also, this echo stethoscope, for inpatient. In our institute, we have 4 sister hospitals. These are smaller hospitals who don't have subspecialists, that they don't have cardiologists, they don't have pulmonologists, they don't have nephrologists. So let's say patient is admitted there, we get a consultation, we do the teleconsultation, the cart comes, we look at the patient, and again, the similar, if you look at the stethoscope, we kind of look at, we auscultate the patient, and it makes a visit complete. You feel like you have really done the justice to that consultation. So, we have been using this one both for inpatient and outpatient telemedicine. So, they say always, one picture is worth 1,000 words. I would say one auscultation or one listen is worth 1,000 words. So let me show you how it feels. So let me try. I don't know whether I can do it, but let me try how it feels to hear it. So you got a very good, crystal, the sound quality is very good. Okay, let's move to the next slide. So Echo has another version, which is a 0.2 version, 1.2 or upper version of the Echo. It's called Echodio stethoscope. It looks really fancy if you look at it. So with this, again, you can use it as a regular stethoscope. You can put it, auscultate it. But if you look at on the left-hand side, the picture we have, this is a very good, and the quality of the sound, the quality of the sound is 60 times amplified. And it also gives you what you call that 1 lead EKG, which is very cool, I think. So Echodio, and we have used in a couple of the clinics, and again, it has all the other features which I told you about Echo Core. So let's see how it looks and how it feels like. So let's go to that one. So again, you have a 1 lead EKG. You have P wave and QRS complex, which is very cool. We don't need an EKG. So let's move to the next slide. I think you all had a good. So again, so far in our clinics, we have been used Echodio and Echo Core mainly. And then, the meat of Echo, which I think is really uh, very, I don't know what is the word, which I think is the very futuristic. I don't know whether it's the English word or not. Very futuristic is the Echo AI analysis. So just got 3 days back, I got a stetho with an AI analytics on that. So which I'm going to use. I've used it in 1 or 2 patients. I'm really excited about it. So it detects atrial fibrillation. It detects heart murmur. It detects bradycardia, tachycardia. So it is really cool. And it is recently FDA approved, and it has sensitivities and specificities are very high. For atrial fibrillation, it is 98.9. Heart murmur, again, it is 87.6. Again, it won't tell you what kind of heart murmur, but it's like, it tells you the initial diagnosis. As you probably know that a lot of nurse practitioner, physician assistant, even the young graduates, we are not very good with all the things. So it's like having an assistant helping you making the diagnosis. And sometimes I tell my residents, it's like a cardiologist in your second room. You can always come cardiologist. Can you have a look of it? So it gives you initial the stimulus to kind of go further into the diagnosis. So again, let me give you a uh, give you a you can give you a demo of it. So let's go to the next slide. And before I go to the next slide, once you put a stethoscope on the patient's chest, you have to wait for 15 seconds. For your time, I'm not waiting for 15 seconds, and then I tell you how it looks. So you can see at the bottom, it says normal sinus rhythm, no murmur detectors, QRS, and heart rate, which I think is really cool. And I think this is going to be the game changer, in the telemedicine world. So I will go to my last slide, I guess. No, I think I have a few more. So let's go. So again, this is, I haven't used it personally, but my colleagues have used it, with this AirPod in your ears, and then you can take the handle and put it here. I think in the way with the COVID pandemic and with this all the infections, this is really cool. So I think this is one, this is very cool feature, and I haven't used it personally, but a lot of my colleagues have used it. But I hope Echo, I hope and wish Echo gives a free AirPods with it, but I'm just kidding. So let's go to my last slide. So again, again, as I mentioned in my first slide, we love telemedicine, we love physical examination, but there's a gap in between. And I believe that to make this telemedicine a success, we have to bridge that gap. And I think Echo provides us that capability to bridge that gap. The quality of sounds is very good. It makes you complete telehealth visit. You're satisfied as a physician that you did justice to it. And the second thing is the virtual exam, which we are doing is almost as good as person exam, which is not a small thing. Nobody would have even thought about it like 2 years back, 3 years back. And then, as I mentioned before, patient has more trust in you, and patient has, you can sometimes share the screen with the patient. So it's kind of really cool and really neat, I would say. So the workflow is also very good. As I mentioned, 15 minutes, boom, you're done with the visit. So I have my colleague who will be speaking you about the workflows. So thank you so much. Thank you everyone for giving me this chance. Have a good day.
Thank you, Dr. Singh. So we started our telemedicine journey with what we called our clinic-to-clinic workflow. This is where patients present to the rural primary care office and are able to complete a telemedicine visit with their specialist located on our main campus. The nurse at the primary care office rooms the patient and is available to assist the specialist during the visit as needed. We began slowly with one primary care office located about an hour and a half from our main campus with 3 specialties: neurology, nephrology, and vascular surgery. Although we started purposely small, we had a large impact on the patients who used telemedicine. As Dave showed in his satisfaction scores, patients were happy with this service. In some instances, we saved patients upwards of 3 hours of drive time coming to our main campus, as well as expensive travel and less loss of work time. As we moved forward, we worked on expanding this program. We brought in 12 additional specialties, as well as 12 additional patient locations. Each specialty could see patients at any one of those 13 sites. As you can see on the map, we expand across a vast area in both Pennsylvania and New York. We created a standard telemedicine room that allowed patients and providers to have the ultimate visit experience: a large screen TV for easy viewing for the patient with high-powered camera that gives the provider the ability to actually virtually control it. The camera also was equipped with a high-quality speaker and microphone to facilitate an effortless conversation. The nurse documentation station is off to the side and uses a separate monitor to avoid interruptions in the provider-patient interaction. As you see, our volumes did start to trend upward, but we were still moving slowly. During this time frame, we had about 40 providers with the ability to complete telemedicine, but the majority of our visits were still being completed by the same 5 or 6 providers. After growing the hub and spoke clinic-to-clinic model, we began looking at other types of telemedicine workflows to assist our patients and providers. We established 4 additional telemedicine options to care for our patients. The inpatient workflow that Dr. Singh talked about, this was originally designed to give consulting specialists the ability to consult to our patients across different hospitals within our organization, limiting that drive time again to the other hospital, and also quicker response times for those critical consults. The second model gave nursing homes the option to complete post-op visits with our orthopedic specialists. The nursing home residents would have the ability to get their post-op x-rays and then their follow-up appointments without ever leaving their facility. Often transporting these patients from the nursing facilities required an ambulance, and the cost of that fell solely on the patients. The next workflow was designed to assist filling gaps that we had with specialty provider needs. We currently have a fully virtual provider for both rheumatology and psychiatry. Patients present to the specialty office and complete their visits with the provider who is strictly remote. The final piece in our expansion was the addition of telemedicine from the patient's home to a specialist in our clinic. Patients would use our portal, Guthrie, to complete these visits. We were still ramping slowly on all these programs. Then the COVID pandemic hit and everything changed. All the building blocks we had were in place to be able to provide safe care for our patients remotely. We just didn't have the scale necessary for this new environment where we're all in. In less than a week, we scaled from 40 providers to 400 providers. To give you an idea of what a vast change that was for us, in January 2020, we completed 90 telemedicine visits. Fast forward to April 2020, 11,000. We began using our workflows I previously talked about in different ways. Inpatient carts now allowed less staff to be required in possibly infected patient rooms. Providers could round on patients virtually and never have to enter the room. All in all, we were quickly able to care for our patients using telemedicine with patients remaining at home, coming to the primary care office, or on inpatient units in the safest of ways. We thought we had every workflow covered. But there was one we didn't account for. What would happen when the specialist was being quarantined but still needed to care for their patients? Out of necessity, we rolled this workflow out, mirroring our previously existing rheumatology and psychiatry telemedicine design to ensure a continuum of care for our patients. Patients could present to the clinic if the nature of the visit required in-person contact, or the patient could be seen completely from home using Guthrie. We had the structure in place for our patients to safely complete visits, but we still needed to ensure providers had the tools to complete a comprehensive exam on their patients. I'll hand it over to Ryan to talk about how we accomplished just that.
Thanks, Alison. As both Dr. Singh and Alison stated, the physical examination aspect of a visit is crucial, and we needed to come up with a solution that would allow our providers to accomplish this without disrupting their workflow while seeing their patients virtually. Enter Eko. Our solution came about in the form of a 4-step process that allowed us to set up and deploy devices in the same day. The linchpin of this process being the plug-and-play simplicity of the Eko device. Using the Eko admin portal, we're able to create a new licensed account called a site that's capable of live streaming. Then we simply take the Eko device out of the box, turn it on, and using the Eko iOS app on an iPad, log in with the credentials generated from the site and pair the 2 devices using Bluetooth. Next, an email is sent out with education documentation on how to facilitate the live stream with the iPad, as well as how providers can access the live stream from their web browser. After that, all that's left is to deliver the devices to the users. In some cases, this meant literally dropping them off at the front door. The question then became, how do we take this process and align it with our already established telehealth workflows? Our clinic-to-clinic hub and spoke model allowed us to simply deploy the devices to our satellite primary care clinics and have the nursing staff leverage the Echo and the iPad combination as part of their standard workflow, with the provider listening to the Echo live stream remotely. Utilizing an iPad really made this system practical in that it allowed the nursing staff to be mobile and use the Echo in any exam room. In the case of the fully virtual rheumatology provider that Alison previously alluded to, we actually deployed the devices directly to the rheumatology specialty office. The inpatient workflow was a little bit different in that rather than using an iPad and the Echo iOS app, we paired the Echo Core device directly to that inpatient cart via a Bluetooth USB dongle, and we leveraged the Echo Windows app to facilitate the live stream. This allowed our consulting specialist providers to auscultate if needed. Similar to the clinic-to-clinic model, clinical staff at the skilled nursing facilities in our community were also able to leverage Echo Cores and iPads with their residents to allow for a more comprehensive exam with their providers. Now, we also mentioned the particularly unique scenario in which we had a provider that needed to self-quarantine for 14 days. Not only were we able to create a workflow that allowed that provider to complete visits from home, but we also deployed an Echo Core and an iPad to that specialty office so that the provider could also auscultate from home. Now, we previously mentioned some of the challenges and needs that were presented with the onset of the COVID-19 pandemic, one of which was ramping our telehealth program from 40 providers to 400 providers as quickly as possible. Now, not only were we able to achieve this, but we had 335 providers actively seeing patients via telehealth within 10 days of the start of this initiative. One of the needs that was quickly identified was, how are we going to provide safe and effective care for not only our patients, but also for our providers? Utilizing the Echo Core live stream functionality really allowed our patients to achieve the quality care that they deserve, while also creating a safe environment for our physicians to provide effective, comprehensive exams. When COVID-19 hit, the skilled nursing facilities in our community were severely affected, and we needed to respond quickly. Being able to rapidly set up and dispense Echo devices with iPads allowed us to get those facilities up and running within 36 hours so that our patients could receive that crucial care that they needed. Additionally, due to the immense increase in telehealth volume, we established a hotline that served as a sort of white glove service that our patients, providers, and other clinical staff could contact if and when they require technical support. The COVID-19 pandemic has really put a spotlight on the value of telehealth. And with that, I'd like to pass it back to Dave to look at what the future of telehealth might look like.
That's great. So thank you, Jagmeet, Alison, and Ryan. Excellent job. I'd like to kind of wrap up here with a little bit around a subjective opinion of what we see in our organization as the future of telehealth and what it looks like going into these post-pandemic, to use a hot word, new norm. So we really feel telehealth will continue to grow, but it's highly volatile still. The maturity of telehealth from an industry perspective will take years to establish, but at a local level, it'll be primarily driven by market competitive dynamics and consumer adoption. And in rural community settings such as ours, we have seen substantial growth. But we saw barriers that remain in place, such as broadband connectivity and consumer distribution. It's interesting to note the generational shift that we are seeing right in the midst of this pandemic as well. So we have the millennial generation who will be the largest generation by 2021, and we are seeing the baby boomers entering Medicare. So millennial values are vastly different from their parents. They focus on access and convenience. Millennial looks at care as, when I need care, I will go find care, and I want care now. They place less value and emphasis on the development of a patient-provider relationship that we've typically seen in the primary care setting. Healthcare industry in general is really a legacy-based industry, but we must also move all the baby boomers through Medicare without bankrupting the system. This means moving care into a lower cost setting, providing efficient predictive care, and removing that legacy of reactive care. So no longer are we reacting, but we are predicting what the complications would be and reducing complications by acting proactively instead of reactively. It's also interesting to note that we started to enter a brand new competitive landscape where geographical boundaries no longer really exist. Driving your organization through this evolution of telehealth is more important now than ever, especially if you want to create a sustainable model and remain competitive in the market in the coming years. I think the next 3 years are really going to define what telehealth potential is, and how quickly we can ramp up quality initiatives and legislative activities to meet the demands of a new population, of a new industry standard. So thank you for joining this webinar, and I think we're going to go to a Q&A session now. Thank you.
Thank you so much, Dave, Dr. Singh, Alison, Ryan. It feels like every time we talk, I learn something new. I'd like to invite all of our presenters to come back on camera, turn on our video, unmute, and to everyone in the audience, go ahead and send in some questions. We've got a number already, so we'll start tackling those. If you have more, please do submit them in Q&A. I'll do my best to direct the right questions to the right people. If I don't, please, someone else, of course, jump right in and take it. We'll start with one for Dr. Singh. Can you use the Eko devices or the Eko stethoscope for auscultating lungs, especially at the time of the COVID pandemic?
Yes, we can use it. It's like a regular stethoscope. You can use it to listen to the heart, and you can use it to listen to the lung sounds. And so it is kind of very simple. In the case of pandemic, you have to be little kind of, as there was one picture where you have you have an AirPod on and you give it to the patient. Like I have this one, you give it to the patient, hand it over, he put it over there, he put it in the back. It has something, but you can kind of use it within your limitations if you're worried about the what you call that isolations and stuff like that. So you have to have a proper workflow for that part.
Thank you, Dr. Singh. Alison and Ryan, you mentioned skilled nursing facilities. One question was, can you clarify, please, when you mentioned community skilled nursing facilities, are long-term care facilities or nursing homes for elderly part of that group?
Yes, as well as assisted living rehab centers. There was about 12 facilities that we rolled out telemedicine to assist them.
Thank you for that. Continuing through more questions, and thank you to our audience here. Keep them coming. We'll answer as many as we can here. One question, technical one. What, if any, challenges did you experience with bandwidth requirements? And either Alison, Ryan, or Dr. Singh, from your experience.
So we actually didn't experience any issues with bandwidth. Again, the majority of our workflows kind of ran through an iPad, so it was all via Wi-Fi rather than being hardwired in. And fortunately, we didn't really experience any issues with bandwidth.
Thanks for that. Another question here: how well did your physicians and APPs accept this process?
Okay, let me answer this question. See, again, we physicians are not the early adopters, of technology. It is what it is, So in the beginning, it was tough to bring physicians to use this because it was different workflow was there. So we have some issues in the past. We kind of incentivized them, as per the quality parameters. But it's like using Uber. Once you use Uber, this is the taxi you want. So once they started using telemedicine, they got more comfortable with that. And then they start demanding, can I have a stethoscope, can I have an otoscope. So they get used to that part. And then it was a big incentive. Like for me, Wednesdays are the days I look forward because that's my telemedicine days. And some days I don't come to work. I sit at home and do all the patients and kind of that work. So that was the incentive. But when the pandemic hit, we didn't have any other option. And that's why we really saw the lot of bump in the number of providers. And once they started using, they're more comfortable. And then what we have seen is that we are using more and more of it.
And along related lines, a similar question: what were some of the main barriers to adoption, and what did you do to overcome them outside of the question you just answered about physicians and APPs?
See, I think, there's some technological barrier which Alison and Ryan will speak from. The main two barriers was physician, which was, I think, the biggest barrier. Patients were barrier in the beginning. They didn't kind of understand it. But, we try to make this telemedicine visit as close to as an in-person visit. For example, if I'm listening to the heart, I'm telling, can you stop breathing? I want to listen to your heart. Can you take a deep breath? So they kind of feel of it. It's a regular visit there. And then sometimes in the telemedicine visit, I share my screen with them. See, this is what I'm seeing here. This is the labs here. So that, and then patient gets more confidence. Now I have patient that says, doc, I don't want to come and see you. You look more handsome in computer. So that's what I've been doing.
In these days, I've unfortunately only gotten a chance to meet you over the computer. So I'm looking
Okay,
forward to when we get past that and I can say hello in person.
sure.
Question, this one might be for Dave. What does your evaluation process look like when you're onboarding new technologies?
So first, we always look at the scalability of the technology, and is it a one-trick pony, or is it scalable onto other entities or specialties? So we look at the flexibility of the hardware. Two, we like to standardize. So we started off with a large conglomerate of multiple vendors offering different peripheral devices, different iPads, different software, hardware. What we really found is it creates then confusion amongst many of our providers. So we look for standardization. So we found, we standardize on on our EMR. So we really rely on our EMR and what's integratable with our EMR, and what can we implement that actually improves workflow and efficiency of the provider, not necessarily takes a provider out of the EMR or out of their clinical setting. We want to keep them in their typical day-to-day environment, but we want to improve the efficiency of their day-to-day. So those are a couple of the things that we look at. And then, of course, there's hardware specs that Alison and Ryan can speak to that I cannot, that, of course, make a difference whether we invest or not.
Yeah, I could actually piggyback off of that, Dave. Kind of like I alluded to earlier, that plug and play aspect is really one of the big features that we look for. It's one thing if it's easy to set up for us, but it's a whole other thing. It needs to be easy for the users to use. For the provider or nursing staff to be able to take the device, turn it on, and be able to essentially use it instantaneously. That's the big thing, because again, we're trying to mitigate the disruption to their workflow as much as possible.
Thank you for that. As a follow-on to your comments, Dave, there's a question, what exactly does scalability mean? How would you put that?
So scalability means that we could do more for less cost. So we take a program or we take a device and we can replicate it without replicating the expense. By growing utilization and reducing expense, we consider that the definition of scalability.
Thank you. And go ahead.
I was going to say that might be a little bit subjective too, but that's how top down we've been defining scalability within our organization.
Thanks. And on a related thread, a question we've got here that we certainly get often enough is the question of ROI for telehealth. Any thoughts you could share there? Of course, you're smiling.
Yeah. So this is a question I hear all the time, and I've asked it many times myself. ROI is difficult. The conception of a comprehensive telehealth ROI really varies across the organization. So there's factors you have to consider. One is, what does your payer mix look like? So are you predominantly fee for service, or do you have a significant number of contracts that are at risk? I'd also look at provider type, acuity mix, your IT infrastructure, and staffing needs. And then, of course, any investment is going to be highly dependent on your institutional objectives, as well as the estimated financial impact. An estimated financial impact is really assessing potential telehealth impact, which we can do through measuring patient experience relative to cost, the impact on revenue, which is hard green dollars, and of course, patient outcomes. So you've got your direct economic drivers in place, but you also have to take into account access to care and providing care in a lower cost setting, or improving the provider-patient satisfaction or that provider-patient relationship. So I think it really depends on your organization, how you're going to define that ROI. Of course, you want it to meet strategic objectives or strategic goals or initiatives that you're focusing in your organization. But I will say the most significant financial benefits for the time being really is around one, changes to the patient's acuity levels and the environment in which we care for the patients, where are we providing care. And two is the increase in new or retained patient volumes. So not necessarily are we measuring ROI in hard green dollars, meaning net revenue from increases in reimbursement, but measuring it in how efficient we are, how we utilize the time that we have during the day, and how it impacts objectives within the organization. So again, I think ROI is really subjective to your own organization, and there is no clear-cut answer on how to define what that revenue impact would be.
I want to add one more thing. So with this telemedicine and using the stethoscope, we have really outreach our market. You know, the places where the cardiologist is going, nephrologists are going, we were not even present there. You know, they are like 250 miles from there. So I cannot go there to see 2 patients, but on the same day, I can see 5-6 patients from different places. So definitely my revenue goes up, the hospital revenue goes up. So that is the, I think, kind of a main asset of using this telemedicine and all this thing. And again, as I mentioned before, seeing this patient is okay, but to make the complete visit, you need physical examination, and this is what we have been doing. And one last point is that when the pandemic hit, this is how we keep our doors open. Thank you.
Thank you. Switching topics here, a question of, in long-term care facilities, I'm assuming the RNs or LPNs are a big part of the workflow to make sure that telemedicine or teleconsultation can be done. Who can share a few words on that?
Brit, can you repeat the question? Sorry, I didn't get the question.
Yes, the question is, in long-term care facilities, I'm assuming the RNs or LPNs are a big part of the workflow to make sure that telemedicine can be done. And can you speak a little bit to who is involved in the workflows in the either skilled nursing facilities, long-term care facilities?
Yeah.
I will let Alison speak,
Yeah, so Alison, I think we could piggyback this one because we have kind of a unique process. One, we tie our partnership with our skilled nursing facilities through a white glove service to get their patients and their residents set up on our eGuthrie portal. So we have easy access to those patients when we need it. And second, in our workflow, we do have, depending on the staffing of that entity, we do have the RNs or LPNs drive a lot of that physical examination under the direction of a physician on our end. So the RN or LPN would be the one placing the stethoscope. They would be the one moving the cart in and out of the rooms or using the iPads and launching the visit. So we kind of have a little bit of a unique structure in how we do that. We also try to make sure that all the RNs and LPNs spend a little bit of time with our physicians who would be doing the examination via telemedicine so that they understand where to place that stethoscope and what kind of physical examination is expected and preferences of each of those physicians. So we try to build a relationship between our physicians and the clinical assistant or nurses on the receiving end so that they anticipate the questions and needs in the physical exam. Alison, anything to add to that from a technology perspective?
No, I think you have it covered.
Thank you. Dr. Singh, there was a question about training. To what extent can you use Eko stethoscopes or Eko Telehealth for training? Can you speak to that?
I'm still learning it. It's a new feature, but you know what you can do is when you are listening using the stethoscope, and you can have in your dual choice. You know, you can listen. Your resident can listen to using your phone, or you can share it and you can save it. You can save it and then listen to that later on. Or sometime what I did was one day was I was not sure what kind of murmur was that. So I kind of recorded it and then sent it to my cardiologist friend. And he said, he needs a stat echo to figure it out. So it's kind of this thing, sharing and saving. I'm still learning it. It's a new tool which I'm using it. So I'm still learning it, but that's what we have been doing it.
Thank you. It's been really interesting to see a number of our partners, customers, who have started to use it for virtual rounding. One person listens, auscultates, and can stream it to a group of fellows or a group of students to help them learn. A very interesting use and creative. Dr. Singh, you've got a nice shout out here. Can Dr. Singh be Guthrie's avatar for telemedicine visits, please? No need to answer that one, but that was a question that actually came in here.
Okay.
There are, here's another. There are a set of Eko specific questions that I think I can answer here quickly, one that's coming in here. One is the question of, is there an AI component to Eko, and was that of help? I'll answer briefly, yes, there is. Eko does have AI available. It's what Dr. Singh shared earlier that detects heart murmur, atrial fibrillation, tachycardia, bradycardia. And in fairness, Dr. Singh just got access to it, so he didn't have a chance to try it out a whole lot. Feel free to jump in, Dr. Singh, but I don't want to put you on the spot since you haven't had a chance to use it yet.
I've used in like a couple of patients. It's really cool. And I think, again, I trained medical school like long time back. So my knowledge of murmurs are not so good. So it's like an extra hand. It's like driving Tesla, if you can't do it, Tesla will do it. So it's kind of that thing. So that's good. And I'm still learning. As I said, we just got it. So I'm still learning that component. But I think this is going to be the future with so many nurse practitioners and physician assistant. If they need some help, AI is really going to help. And it's not going to diagnose it for you. It's going to relay you in that. Let's say murmur detected or AFib. So you can do further investigations or you can do further kind of stuff for that. That's what I believe in so far.
Thanks. The other Eko related questions, one is about security, HIPAA compliance, and the short answer is yes, it is secure, SOC 2 certified, and HIPAA compliant. And related to that, there's a question about EMR integration. Short answer is yes, and we're very happy to talk with you about that. So just reach out and let us know. This has been fantastic. Thank you to all of you. Dr. Singh, Dave, Alison, Ryan, thanks so much for sharing your experience. I'm going to share with our audience here contact information. There we go. So if you have any further questions, and we'd love to continue the conversation with you, anything at all, please reach out to us, either through email, support@ekohealth.com, through our website. You can contact us from there. You can also subscribe if you want to keep up to date on updates, or give us a call or text us. Again, to our panelists, to our presenters, thank you to your whole team who made this happen. And many of you in the audience on the front lines, thank you for what you're doing every day. We really appreciate it. And reach out to us. We're looking forward to continuing the conversation. Thank you.